Hello everyone, welcome to our new video. In today's video, I'll be discussing Chapter 10, Chapter 11, and your Chapter 12 of your ICT 10 CM 2020. So if you're new to my channel, don't forget to hit the subscribe button, hit the notification bell so that you will be notified every time I have my new upload. So I hope these videos are helping you guys, and I hope it helps with your studies, and good luck in your exam very soon. So in today's video, I'll discuss first the chapter 10 diseases of your respiratory system. So there are two common conditions that we may encounter under your chapter 10, that is your COPD, chronic obstructive pulmonary disease, and your category for your COPD is your J44. So when you go to your category J44 in your book, you may see conditions included in this category include asthma with chronic obstructive pulmonary disease, chronic asthmatic bronchitis, chronic bronchitis with airways obstruction, chronic bronchitis with emphysema, chronic emphysematous bronchitis, chronic obstructive asthma, chronic obstructive bronchitis, and chronic obstructive tracheobronchitis. Those are the common conditions that are also included under your category J44. The documentation must exactly the same with this under your includes notes. Now, because we have a separate code as well for bronchitis, and we have a separate code for asthma, and we also have a separate code for your emphysema. So be careful with those. We need to have these terms in order to classify them under the category J44. When you go again to your J44, we have these options under your category J44. We have your subcategory J44.0 COPD with acute lower infection, respiratory infection, J44.1 COPD with acute exacerbation, and J44.9 COPD with your unspecified. Now, we have a term here, acute exacerbation. So we will be discussing later on what do we mean by your acute exacerbation. Next common condition is your asthma. Your asthma is a chronic lung disease and it affects the airways. So the problem there is there's a narrowing of your airways and there's a swelling, and that swelling produces your extra mucus that may lead to your difficulty of breathing or cough most of the time. So your asthma is coded by severity. When we say severity, we are saying is it mild, moderate, or severe? And if there are also different types of asthma that we may also encounter in your medical conditions or in the medical records. Okay, so when you go to your categories J45, we have your subcategory or subcategory J45.2, and under that we have your subcategory, and it's divided between uncomplicated, acute exacerbation, or your status asthmaticus. Obviously, when we say uncomplicated, there's no complication of your asthma right now. When we say acute exacerbation, we will be discussing that later on. When we say status asthmaticus, your condition is no longer responding with the medication. So please be careful when you have your asthma and don't overdose your medication, because that may lead to your status asthmaticus. And as you can see in the differences of your codes, we have mild intermittent, mild persistent, moderate persistent, and severe persistent. So as you can see, the codes are divided based on your severity and also divided based on uncomplicated, acute exacerbation, or your status asthmaticus. Okay, this is just an introduction with our guideline, because we will now starting discussing the what do you call this one, the chapter specific guideline for your chapter 10, and this is the first one, chronic obstructive pulmonary disease, or your COPD, and your asthma. So as an introduction a while ago, acute exacerbation of chronic obstructive bronchitis and asthma. When I say chronic obstructive bronchitis, that is under your COPD, so that's still the same as COPD. So the codes in categories J44, which I showed you a while ago, and J45 distinguish between uncomplicated, correct? As you can see in the example a while ago, as you can see the tabular list a while ago, so it's uncomplicated cases versus those in acute exacerbation. So as you can see a while ago, we have an option for acute exacerbation. So what do you mean by acute exacerbation, guys? An acute exacerbation is a worsening or decompensation of your chronic condition. So it's just like a crisis. It's worsening or a decompensation of your chronic condition. And acute exacerbation is not equivalent to an infection superimposed on a chronic condition, though an exacerbation may be triggered by an infection. So as the common term that they are using most of the time in the medical record or even in the exam is like decompensation, worsening, like that. They mean sometimes they will not mention the word exacerbation, so you need to know what is exacerbation means, and that is just the worsening or decompensation, because they will challenge most of the time. They will not put in the word exacerbation, and they just put in the word worsening or decompensation. So you should know. I think you just need to put a note there in your ICD-10 CM book. Okay? Next guideline is your acute respiratory failure. I usually put in the code here J96. Okay? 0.0 to be specific. Actually 0.00, 0.01, 0.002, like that. So there are options under your subcategory J96.0. So every time you see acute, my common notes here is ARF, acute respiratory failure, J96.0. Okay, and under your guideline tells you when you will going to use J96.0 as a principal diagnosis or a first listed diagnosis. So here's the guideline. First, before moving on, let's check subcategory J96.0. You can go ahead and check your book. J96.0 is acute respiratory failure, while J96.2 is acute and chronic respiratory failure. And we also have a different code for chronic, and that is J9. As you can see, J96.0, there's a gap. There's no J96.1 here. That is the code for chronic respiratory failure. And when if it is acute and chronic, use your J96.2. Now, here is a few reminder, because I encountered this when I took my CRC or your risk adjustment coding. There's a combination code for acute and chronic respiratory failure. You don't need to code them separately with your acute and chronic, because we have a separate code for acute, we have a separate code for chronic, and we also have a code for acute and chronic. So don't be confused if the documentation is specifically saying acute on chronic or acute and chronic. We will going to use J96.2. Now, that is just an additional info, but the guideline here is telling us when we will going to use acute respiratory failure as a principal diagnosis. Obviously, if that's the reason for encounter, right? Because our principle is, if that is the reason for encounter or the focus of treatment, that should be your principal diagnosis, correct? Yes. So, acute and chronic respiratory may be assigned as a principal diagnosis when it is the condition established after study to be chiefly responsible for occasioning the admission to the hospital, and the selection supported by the alphabetic index and the tabular list. That is just a summary. If that is the reason for encounter or the reason for admission, it should be the principal diagnosis. But the opposite, if that is not the reason for encounter, if acute respiratory failure is not the reason for encounter and it only happened after admission, and there's another reason why the patient is being admitted, obviously you cannot use it as principal. And that is the second guideline, acute respiratory failure as secondary diagnosis. Obviously, respiratory failure may be listed as a secondary only if it occurs after admission, and if the present on admission, and if it is present on admission but does not meet the definition of principal diagnosis. So like for example, you are admitted with pneumonia, okay? And the primary reason for pneumonia, for your admission is pneumonia, and then you suffer, you develop, after the admission, you develop acute respiratory failure. I mean, meaning the acute respiratory failure happened after the admission, so it's no longer the primary diagnosis. You can add it as as a diagnosis, but it should only be a secondary diagnosis. Okay? What if sequencing of acute respiratory failure and another acute condition? So we have two acute conditions here. Um, it depends on the reason, I mean, the focus of treatment actually. So when a patient is admitted with respiratory failure and another acute condition, and which is your myocardial infarction, um, remember your AMI when I discussed chapter 9, that is acute myocardial infarction, or your cerebrovascular accident, or acute um, cerebrovascular accident, okay, aspiration pneumonia. The principal diagnosis will not be the same in every situation. So, this applies whether the other acute condition is respiratory or non-respiratory condition. So, sequencing or selection of your primary diagnosis dependent on the circumstances of encounter. What if they qualify both? If both the respiratory failure and the other acute condition are equally responsible for occasioning the admission to the hospital, and there are no chapter-specific sequencing rules, that guideline regarding two or more diagnoses that equally meet the definition of principal diagnosis, Section 2, letter C, may be applied in this situation. You can use either one of them. That is the guideline. We don't need to go through Section 2 and C. The guideline here is you can use both of them. It's either any of them. You can use both of them. It depends on how will you go. It's up to you what you will going to use first, because they both qualify, so they can be both primary diagnosis as long as they equally responsible in the reason for admission. Okay? If the documentation is not clear, obviously you need to query the provider, because if the documentation is clear as to whether acute chronic respiratory failure and other conditions are equally responsible for occasioning the admission, query the provider for clarifications. Okay. Next, influenza due to certain identified influenza virus. Now, for influenza like your AH1N1, like that, your SARS, like that, okay. Because those are caused by, I mean, no, that's not caused by your influenza rather, but those are caused by viruses, okay. So, code only confirmed cases of influenza due to certain identified bird flu, like that, your identified influenza virus category J09, and due to other influenza virus category J10. So if it's influenza virus, identified influenza virus J09, and if it's other identified influenza virus, use your J10. These categories are being used if it's already confirmed, because we are only coding influenza viruses if infection, if it's only a confirmed cases. Okay, we cannot code if it's not yet confirmed. This is an exemption to hospital inpatient guideline. Okay, of course, there's an exemption to hospital inpatient guideline, but I will not discuss this one because this is mostly on the inpatient setting. Okay. In this context, confirmation does not require documentation of positive laboratory. As you can see, it's the same as your AIDS or your human immunodeficiency virus. It's the same, that we can only code them if it's confirmed cases. Same as Zika virus, we can only code them as if it's confirmed cases. And the documentation is already, I mean, it does not require any documentation at all of positive serology, as long as the provider already documented as AIDS or influenza virus infections, like that, or Zika virus infection. That's enough. You don't need to go through and check laboratory testing if the documentation is already positive. Okay? However, coding should be based on the provider's documentation statement that the patient has avian flu or other novel influenza A for category J09, has another particular identified strain of influenza such as H1N1, H3N2, but not identified as novel or variant. Use your category J test. Just like we have a specific and we have for others. J09 for specific, novel influenza A. Specific for influenza A. For other, use your category J10. If it's not yet unidentified yet, use your J11. Okay? If the provider records suspected or possible or probable avian influenza or novel influenza or other identified influenza, then the appropriate influenza code for J11 influenza due to that identified influenza virus should be assigned. Okay? That is the difference. Your J09 is specific to influenza A. For other like other strain like H1N1, H3N2, use your J10, and for J11, if it's not yet identified type or suspected probable type of influenza, use your category J11. Okay? Next, ventilator-associated pneumonia. Now, remember guys, if the patient is hooked up with your ventilator, there's a foreign body there. There's a tube inside the body. It is a foreign body. Now, the common reaction or the common complication rather, most of the time, is your infection. Okay, remember that. That's why we need to have the sterile technique when we, as much as possible, should be sterile as possible. Because these may cause your infection and this may result to your pneumonia. Now, documentation of ventilator-associated pneumonia is very specific in the guideline that is associated pneumonia. Ventilator-associated pneumonia, meaning that pneumonia is due to that ventilator hookup. So as with all procedural or post-procedural complications, code assignment is based on the provider's documentation of the relationship between the condition and the procedure. It should be clearly documented, guys, that the pneumonia is due to the ventilator. Okay? It should be specified in the documentation by the provider that pneumonia is caused by the ventilator. Okay, so we have a code for that, J95851. Ventilator-associated pneumonia should be assigned only when the provider has documented ventilator-associated pneumonia or VAP. You can also add additional code, which is your organism that causes pneumonia, which is your Pseudomonas. This is very common in the hospital, and these Pseudomonas, guys, are multi-drug resistant antibiotics. So we should not, we need to get rid of this bacteria because these are the common causes of your pneumonia. And those are only acquired most of the time in the hospital. Okay, do not assign an additional code for J12 to J18 because their category for pneumonia for different types, for normal pneumonia, for other causes, J12 to J18. Unlike with J95851, where we are very specific, that it should be ventilator-associated pneumonia. You don't need to use your J12 to J18. But what if the reason for encounter is pneumonia? Okay, with other causes. And then the patient suddenly developed, it was hooked up to ventilator, and the patient also developed ventilator-associated pneumonia. So there are two pneumonias now. Because the reason for encounter, for example, is pneumonia due to other microorganism, you need to code the category J12 to J18. And then suddenly the patient also developed ventilator-associated pneumonia. What should be the guideline? That is the next guideline. Okay, before moving on, let's discuss this first. J95.851 should not be assigned for cases where the patient has pneumonia and is on mechanical ventilator and the provider not specifically stated the pneumonia is related to your ventilator. As I mentioned a while ago, they should be documenting that pneumonia is really related to that ventilator hookup. Next, as I mentioned a while ago, what if the patient encounter, like for example, the patient is being admitted with pneumonia due to other causes, and then the patient suddenly develops ventilator-associated pneumonia as well. So a patient may be admitted with one type of pneumonia, like for example J13 due to streptococcus, and subsequently develop VAP or VAP, ventilator-associated pneumonia. In this instance, the principal diagnosis would be the appropriate code from J12 to J18. for the pneumonia diagnosed at the time of admission. And then code for J95.851 would be assigned as an additional when the provider is also documented as presence of ventilator-associated pneumonia. So here in the guideline here, guys, you cannot code already your J12 if the condition is already if it's only ventilator-associated pneumonia. But here in the guideline here, the patient is admitted with a different type of pneumonia, and then the patient suddenly develop your VAP. So we can use them both because there are two types of pneumonia happened in the encounter. Okay? Next, so we're done with chapter 10. So if you have any question, guys, please comment below. Or if you need examples, I cannot really put in an example a lot here because this may lengthen the video. And I'm planning to create a video for reviews per chapter so that it will be very detailed videos, and it should be organized. I don't want to include more examples here as because it may lengthen the video. Okay, so I want to have a separate video for each chapters. I will going to review you guys each chapter, so don't you worry if you don't have your examples yet. Okay, so it's okay to study first the guidelines, and then as we go through the ICT-10 review, we will going to incorporate the guidelines when we have the questions already. Okay, stay tuned. So let's move on to your chapter 11. Your chapter 11, we don't have a guideline for diseases of your digestive system, but you may encounter a lot conditions of your digestive system. I'll just go ahead and check the categories. We have diseases of this. Your codes are divided based on your anatomical location, or based on your anatomy. So from your mouth to your anus. You have diseases of the esophagus, stomach, and duodenum. Those are commonly termed as your upper GI. Okay, upper GI, upper gastrointestinal. Okay, esophagus, stomach, and your duodenum. They require to use an additional code to identify alcohol abuse and dependence most of the time because there's the common condition that we may encounter in your esophagus, stomach, and duodenum is your ulceration. Remember, like for example, the patient is alcoholic, right? Remember that. The common condition that we may encounter is your peptic ulcers or your esophageal ulcer, duodenal ulcer, or your stomach ulcer. Okay, those are common conditions that we may encounter. We also have a separate code for diseases of the appendix. Oh my goodness, these are common cause conditions that we may encounter, and the coding of this is difficult. This is my struggle most of the time. Like, a lot of students are very happy if we don't have any guideline with that specific chapter. Now, the problem is when you do the actual coding and you don't have any guideline at all. Okay, your basis should always be the documentation or the medical record. Unlike if we have a guideline, I can easily decipher what should be the code, right? If we have a guideline, but if we don't have any guideline at all, we don't have any references. So we will going to base most of the time on the medical record, and the correct answer will also based on the medical record or based on the scenario. So for me, it's quite struggle if we don't have any guideline at all. Because if we have a guideline, we have a basis or we have a reference what should we going to use, right? But if we don't have any, it's based on the documentation or it's based on the medical record. So code for appendicitis and other diseases of your appendix includes acute and if it with or without peritonitis. When we say conditions may also be in your appendicitis, codes are also differentiated if it's ruptured or not ruptured. And it's also differentiated between your with or without peritonitis. Okay? Non-infective enteritis and colitis is coded with a range of K50 to K52. You just put in, when we say enteritis, it's now your small intestine. Small intestine for enteritis. Okay? For colitis, your colon is for your large intestine. Okay? When you go to Crohn's disease, there's no codes. There's no specific code for Crohn's disease, but they have your enteritis. When you go to your alphabetic index and go through, check your Crohn's, you may see an instructional note there to see also enteritis like that. Okay, that is your chapter 11. Okay, diseases of your digestive system. Let's move on to your chapter 12, diseases of your skin and subcutaneous tissue. As much as possible as I want to put in images here, I may um I have a struggle also doing getting an images because it may be subject to copyright. So most of the time, as when you have your book, you have these images there for your diseases of the skin and subcutaneous, very specific to your pressure ulcers. We have a few guidelines for your chapter 12, but we have a lot of codes under your chapter 12, which is your L00 to L99. Okay, but common guideline that we may encounter is only the pressure ulcer. Okay, so we have pressure ulcer stage codes or pressure ulcers. We have your code for pressure ulcers L89. Okay, and that is for your pressure ulcers. Combination codes that identify when we are coding pressure ulcers. Remember the other term for pressure ulcers. We have your decubitus ulcer. Okay, when you go to your L89, you have that under your L89 category. Those are different terms that we are using. Pressure sore, like that. Pressure ulcer. Decubitus ulcer, like that. So when you are coding, so what is your pressure? What is the common cause of your pressure ulcer? Like if the patient is long-term bedridden, that's why in the hospital we need to rotate the patient's Q2 hours, Q4 hours, Q6 hours, like that. So we need to rotate the patients to get rid of these pressure ulcers. And the common site that the patient may suffer pressure ulcers, I remember, it's your bony prominent areas like your hip. Remember that? You have your elbow. Okay, you have your shoulder. Okay, any body prominent areas. Okay. Now, since your pressure ulcers happen in some bony prominent areas, combination codes that identify the site. When we are coding pressure ulcer, we need to know the site of the pressure ulcer as well as the stage of the pressure ulcer. So there are two things that we need to consider when we are coding your pressure ulcer. Remember, you need to know the site or the body prominent site and the stages of your pressure ulcer. Your stages of pressure ulcer, you have your stage 1, stage 2, stage 3, and stage 4. When you go to your tabular list, you can see the differences of your stage 1, stage 2, stage 3, and stage 4. If it is, you are lucky enough, most of the provider are documenting the stage because that's very important. Okay, also need to know the stage because that is, we don't need to end up using unspecified without knowing the stage. Okay? So, as much as possible, we need to be very specific. Okay? Here's the example. When you go to L89.0, pressure ulcer of the elbow, and you also have a pressure ulcer of the right elbow, pressure ulcer of the left elbow, and when you go down, you have pressure ulcer of the back. Now, as you can see in your pressure ulcer of the right elbow, it's different, divided based on your unstageable for 0. The last digit means 0 is unstageable. The last digits will tell you if stage 1 is 1, 2, 3, and 4. And we have unspecified stage, which is your 9. Okay, as you can see the differences there. When I say, like for example, in the question, you already see that the stage is stage 3. In your choices, you need to have the last digit should be a 3 because we are talking about stage 3, correct? And that will easily eliminate choices in your exam. Remember that, okay? And we also have 9 and 0. We will be discussing the difference between unstageable, which is the L is 0, and the 9 for unspecified, okay? Here's the guideline for that. Assignment of code for unstageable. Like, before moving on, guys, what if, like for example, okay, because it's not specified in this guideline, what if the patient's like having stage 3 pressure ulcer in the elbow, and the patients also have stage 2 pressure ulcer at the back. So there are two different sites, correct? Okay, and there are two different stages. Excuse me. Put a note here in your guideline that if the patient has multiple sites, okay, the guideline here is code all sites. Okay, code all sites of pressure ulcers and code first the highest stage. Keep in mind, it's not stated in the guideline, but if you encounter like questions like that, it's very important note that if you have multiple sites of pressure ulcer and they have different stages, code all multiple sites, code all sites, code first the highest stage. If like for example, so what if they're all like for example there are 4 sites and all the 3 sites are stage 3 and one site is stage 2. How should I code for the 3 stages for the 3 sites that is stage 3? You can code either the 3 of them. Code first either the 3 of them, but it should be you should going to code first the first 3 sites with the stage 3 before coding your stage 2. Okay? Next, assignment of the code unstageable pressure ulcer L89 and the last digit is 0. As you can see in the example a while ago, the last digit for unstageable is 0 and the last digit for your unspecified is 9. Now, assignment of the code unstageable pressure ulcer L89.0, dot 0 should be based on the clinical documentation. These codes are used to be pressure ulcers whose stage cannot be clinically determined. When we see unstageable, it should be documented by the provider that it is clinically unstageable or clinically not determined. But for this code should not be confused with the codes for unspecified, because for unspecified, there's no documentation at all of the stage. Unlike with your unstageable, it is all already specified that the provider cannot clinically determine the stage of the patient. The common example here, if there's an scar or like plastic, something like that, so that's an scar, so we cannot see how deep the ulcer is. So that is clinically undetermined, so that should be unstageable. For no documentation at all for the stage, that should be coded under your L89 and the last digit should be 9. Okay? Documented pressure ulcers. The assignment of pressure ulcer stage code should be assigned by the clinical documentation and based on the alphabetic index. Okay? Patient admitted with pressure ulcers documented as healed, or the patients already don't have any pressure ulcers, so if no code is assigned if the documentation states that the pressure ulcer is completely healed at the time of the admission. Guys, do not forget this guideline, because sometimes they put in the patient suffered stage 2 healed ulcer. Oh yes, there's a stage 2. There's an ulcer stage 2. I should be coding stage 2 pressure ulcer. Guys, remember, if it's healed, no need to use for L89. Okay, don't be confused. Don't be tricked with that questions. Okay, if it's healed, put a note there. No code should be used if it's completely healed. Okay, but if they say that is still on the healing phase, is the pressure ulcer present? Is the pressure ulcer still present? Yes, because when we say healing, the condition is still present, but it is already healing. So pressure ulcers described as healing should be assigned to category L89, or pressure ulcer stage code as per the medical records. So if the documentation does not provide information about the stage of healing pressure ulcer, assign the unspecified. If it's unclear, query the provider. But for ulcers that were present on admission but healed at the time of discharge, use the stage at the time of admission. Okay, what if the patient evolves, or the patient admitted with pressure ulcer evolving into another stage during the admission? So If the patient is admitted to an inpatient hospital with pressure ulcer at one stage and it progresses to higher stage, which may also happen most of the time. So we have two separate codes. Remember my guideline with glaucoma? Like, if it evolves from stage 1 to stage 2, for glaucoma, code the highest stage. But for pressure ulcer, do not code the highest stage. As per your guideline, two separate codes should be assigned, and the first code should be the code for admission, followed by the highest stage reported during the stay. I need to be clear with the highest stage reported during the stay because, for example, the patient is admitted at stage 1. So that should be your first code because that is your stage 1. And then it evolves to stage 2, stage 3, and at the before the patient is being discharged, the highest stage being achieved is stage 3. So we're going to use to report the stage 1 during the admission and the stage 3 only because that is the highest stage achieved during the stay. We will not going to report the stage 2 because that is not the highest stage, correct? So keep in mind, we have a two separate codes for your pressure ulcer that evolves from another stage during the admission. Pressure-induced deep tissue damage. This is a new for 2020. For pressure-induced deep tissue damage or deep tissue pressure injury, assign only the appropriate code for pressure-induced deep tissue damage, which is your L89, and the last digit is 6. Non-pressure chronic ulcer, I think this is category L97. Just verify, I don't have my booklet here. So L97, I think, when you go to your non-pressure ulcers. So these are, when I say pressure, obviously it's due to pressure ulcer. If it's non-pressure, due to other conditions. Other condition that may suffer non-pressure chronic ulcer are the patients who's having diabetes. Remember that? It's not caused by pressure, remember? But it may be caused to your diabetes because there's no blood supply anymore. So it's still the same guideline. There's no other guideline here. Patient admitted with non-pressure ulcer documented that it's healed, is still no code if it's healed already, correct? It's the same with your pressure ulcer. Your pressure ulcer documented as healing, it's also the same as your pressure ulcer. If it's still healing, you can still code them. Okay? Patient admitted with non-pressure ulcer that progresses is still the same. You need to have two codes. Code first for the first, code for the stage of the admission, and the second code for the highest stage achieved during the stay. Okay, I think that ends your chapter 12. And we'll be discussing chapter 13 and 14. I cannot include chapter 15 in the next video because that's too long. I have a separate code, separate video for your chapter 15 because that's quite long. I try to upload 13 and 14 during the weekdays, and so that on the weekends I'll be discussing chapter 15 only. So I hope you guys are healthy. Okay, so stay safe and enjoy studying because coding is really a great job, and it offers you a lot of opportunities. Thank you, and until the next video.